Okay, and we are live. Hello, web shadowers. Thank you all for joining our session this afternoon. Today, we have the pleasure of hosting Dr. Amanda Shi, who will be teaching us about anesthesiology and critical care. As always, please remember that the Google form will be posted in the chat box and in the description of this video at the very end of the session. With that being said, Dr. Shi, you can get started whenever you're ready.
Thank you so much to the Web Shadowers team for inviting me to share about my specialty. I'm really excited to be able to share about anesthesiology. And on top of that, I'm also a critical care physician, and very few people recognize that anesthesiologists can also be ICU doctors. So I wanted to just launch right into my presentation. Just to get started on a little bit about myself, I'm originally from Metro Detroit. I am currently in Boston, Massachusetts, though, and that's where I'm practicing. My undergraduate was a little weird. I actually, fun fact, do not have a high school diploma because I went to college early in Western Massachusetts. I then transferred to the University of Michigan and got an engineering degree. So this, question that always comes up about what kind of, pathways people can take to medicine, it's whatever pathway makes sense for you. I then went to medical school at a brand new medical school. So another thing that's kind of non-common, but I was part of a charter class and then graduated and matched into my top choice program at Henry Ford and Massachusetts General Hospital. So an area here that is a little interesting is that in the field of anesthesiology, we actually have a number of programs that are separate. So we have some programs that are 4 years in one place and other programs where it's 1 year internship separately from a 3-year residency, which is what I matched into. And so when I matched, I actually got 2 places where I matched to, and that was my internship, which, like I said, was at Henry Ford in Michigan, in Detroit, and then my residency was at Mass General in Boston. So I moved after a year. And then I also stayed on for 1 more year for fellowship so that I could become an ICU doctor as well. Now, many of you guys probably have an idea of what anesthesiologists do if you're interested in checking it out as a specialty, but to give you a little more of a formal definition, anesthesiologists evaluate, monitor, and supervise patients before, during, and after surgery, specifically to deliver anesthesia and to be part of leading the anesthesia care team model. And this, our job can look a little different depending on what type of practice and what type of hospital and center you are in. So anesthesiologists are very versatile physicians. We can do our own anesthetic. So that means that I can go in and be the person that introduces myself, sees the patient before surgery, prepares for the patient for surgery, and then takes them into the operating room and provides the anesthetic for the entire case, then takes them to recovery. Or I could be part of a team, which is my current practice, where I actually supervise residents, so people or anesthesia trainees that are learning how to do anesthesia during residency, or nurse anesthetists. So that's the team that I will work with. So that means that I will be potentially in a couple or overseeing a couple different operating rooms, not just one operating room, and overseeing a couple different patients simultaneously. There's also a third type of person that can provide anesthesia, and that is an anesthesiologist assistant. That is another type of provider that anesthesiologists can also supervise in the operating room. Big picture, we come up with a anesthesia care plan. We can manage pain management, and we can also do critical care medicine. So to jump into this critical care anesthesiologist thing, the things that most people think of when they think of ICU doctors is that most people consider internal medicine to pulmonary critical care as the pathway to become an intensivist or an ICU physician. And that is the most standard way that many physicians become intensivists. However, there's other pathways. Actually, surgical residents and surgeons can do a trauma and critical care fellowship, so they can also be ICU doctors. Emergency medicine physicians can also be ICU doctors because there's a fellowship for that, and anesthesiologists can be ICU doctors. During the pandemic, it has become, has become more clear that anesthesiologists are incredibly important and valuable physicians, because we are actually the ones that are very comfortable with airway management, being able to insert endotracheal tubes or breathing tubes, the process known as intubation. We're also very facile with managing ventilators, because that is what we do in the operating room every single day. On top of that, we are comfortable with pain medications, sedating medications, as well as medications to keep blood pressure up. So it's a perfect fit for anesthesiologists to also become ICU doctors. So the definition more formally of a critical care anesthesiologist is that we supervise, coordinate, and manage a patient's care within the ICU. So something that I've been asked before is that it's a misunderstanding that I would be an anesthesiologist in the ICU. In fact, my role as an anesthesiologist is in the operating room setting in the ICU. When I am on as the ICU doctor, I'm actually the physician overseeing the care of the ICU patients there. Now, another thing that I think is important to delve into anytime we talk about any specialty is the gender breakdown in a specific specialty. Now, as an engineer, I will say that there was a much more significant gender disparity within the field of engineering between men and women. There are substantially more men in engineering. And in anesthesiology, what I'll say is that women are still a minority. So that's just something to be aware of. I think that the operating room environment is one that can breed certain types of interests, and there can be certain issues with occupational hazards when you become an anesthesiologist that may not be as appealing to some women. But this is changing, and obviously I am a woman that's an anesthesiologist, and I'm very happy with my career. So don't let that stop you. Now, I've sort of alluded to this, but how do you become an anesthesiologist? Well, obviously you finish college, you do medical school. Our residency is 4 years, and our fellowships are 1 year each. So some people actually do more than one fellowship because they're only a year long. But typically, at minimum, a residency program needs to be 4 years long for anesthesia in order to become a board certified anesthesiologist. Now, for fellowships, I like to go into this too, because I think it's really important for people to realize how many different areas in the hospital and how many different areas that we can have expertise in as anesthesiologists. Now, cardiothoracic anesthesiology, those are anesthesiologists that train additional years so that they can provide anesthesia for open heart surgery, cardio, any kind of valve surgeries, things in the chest. The main thing about that training is that they get expertise in transesophageal echocardiography, which is using the camera that goes into an esophagus to view an ultrasound image of the heart and be able to analyze, assess, and use that information to guide therapy for a patient. So that is that. Critical care anesthesiology, which is what I do, which is an extra year of training in order to become an ICU doctor. Neurosurgical anesthesia, anytime someone's getting brain surgery, cranies, those are things that have specialized things that we need to be considerate of, and therefore they have extra expertise there. Obstetric anesthesia. So more and more now, our obstetric population, our pregnant women are coming in with more and more comorbid diseases. So some women with congenital heart disease are becoming pregnant and they're delivering, and their physiology is totally different from a normal healthy patient's physiology. And pregnancy and delivery is another time in which the physiology changes substantially, and as a result, it's really important to have people that understand how the body changes undergoing labor and be able to manage that situation. And many people think more so of anesthesiologists as the epidural fairy. We come in, we place an epidural during labor, and we take away a patient's pain. So I will say obstetric anesthesia is a very gratifying and satisfying field to go into, because we get that immediate gratification of placing an epidural and seeing a patient who is in excruciating pain from contractions from labor, then calm, comfortable, and able to actually take a nap or relax. blocks. Pain medicine is another area that we can become specialists or experts in. There's two kind of categories of that. So acute pain is someone who will specialize in hospital procedures or things to be able to manage. Usually surgical pain is where that expertise is. So we can get extra training in doing blocks, regional blocks, which is basically using an ultrasound to identify specific nerves and then be able to put numbing medicine around those nerves. So if any of you have ever had surgery on your extremities, if you broke a bone, things like that, we can actually put numbing medicine in the brachial plexus, which are the nerves that go from your cervical spine all the way down to your arm, so that the entire arm is numb, and people don't even have to go completely to sleep when they get that, and it also helps with pain. In terms of chronic pain, a lot of our patients have chronic lower back pain, and they can go see a chronic pain specialist that's an anesthesiologist in order to get different steroid injections in their spine or epidural steroid injections. They can also insert devices such as stimulators, so that allows for pain management for those patients. Pediatric anesthesiology, so you do need specialized training in order to take care of the tiny babies that need surgery, babies that have different congenital illnesses or have any kind of other surgical needs. There is specialized training necessary in order to go down that path. And then finally, palliative care is another pathway in which we can go down and become experts in, because we are very comfortable and facile with pain medications. Now, if you guys were coming with me to the operating room, I wanted to share with you what my day kind of typically look like. Now, I do want to emphasize that my day in the operating room is representative of an attending and not of a resident. Now, when I was a resident, I went in much earlier and I stayed much later. I would do more 24-hour call, and my schedule was a lot more sporadic and much busier. As an attending, my schedule is a little different now, and typically it looks something like this. So my day on a regular day in the operating room is from 7 a.m. to 5 p.m. So I would have you meet me at 7 a.m. We would get into our scrubs. We would go into the preoperative area. So the pre-op area is usually kind of the same area as where our patients recover as well. That's where our patients get checked in. They switch into their gowns, the hospital gowns. The surgeon goes in to say hi to them. We go in and say hi to our patients. We make sure that the appropriate medications were taken or not taken by the patients. We place an intravenous line, and then we make sure that everything is ready and safe for the patient to proceed with surgery. The pre-op area is the time when we would identify if a patient has had something that stops them from being able to safely undergo surgery. So many of you guys may know, we do not let patients eat or drink before surgery. So we have had patients come in to the pre-op area and say, oh yeah, I just had a breakfast sandwich on my way in, and we're like, no surgery for you, unless it's an emergency. If it's an emergency, we will proceed with surgery. But typically, the majority of our surgeries are elective procedures that patients are coming in scheduled for. So at 7 a.m., we go and look at all of our patients, and then usually we'll start all of our cases around 8 a.m. So when I say start cases, that usually just means that the patient is going into the operating room before 8 a.m. We're getting all of our monitors and everything onto them. We are getting them safely anesthetized, so then the surgeries can begin. Every institution is a little different in what time they start surgery. Some surgeries start earlier at 7 a.m., but my particular institution, we start surgery at 8 a.m. Now, I alluded to earlier that I can actually supervise multiple operating rooms. So sometimes I have to be in two places at once, which can be challenging. So I can call upon my colleagues to help cover a room if I need, or, sometimes I just have to make sure that someone is safely asleep and anesthetized before I go on to another room to ensure that's the case. Now, some of the most dangerous parts of anesthesia, as many people liken anesthesia to flying a plane, is takeoff, which is induction, or sending a patient to sleep and securing the airway. So if someone is undergoing a general anesthetic, placing a breathing tube or a mask airway, those are the things that we could get into trouble with, meaning if you're not able to place it properly, or if a patient loses their blood pressure because of our anesthesia medications, that's a very dangerous and critical critical part of the anesthetic. After we've taken off and we are on cruise control, typically that part, there's a lot of maintenance and other things we're thinking of, but it's not as busy of a time. And then finally, wake up is another time that's really, really critical because patients have to be able to be breathing, they have to have all the anesthesia off, and they have to be able to follow commands in order to get a breathing tube out or breathing device out, or to be awake and safe after their surgery. We're also, while we're maintaining our patients, we're making sure that their vital signs are stable. We're providing pain medications as well as medications to prevent nausea, because frequently our anesthesia medications can cause a lot of nausea. Now, what you'll see in this typical day is that we have a morning break, a lunch break, and an afternoon break. Now, this is really, really important because in anesthesia, we can't just walk out and abandon our patients. We have to be supervising. There has to be an anesthesia provider, an anesthesiologist with the patient at all times when they're undergoing anesthesia. So that actually means that when I'm the person that's providing an anesthetic, I cannot just walk out and go get a sip of water or drink my coffee or run to the bathroom. I do actually have to have one of my colleagues come back in and make sure that there's someone there so that I can go out for my break. Now, I do want to switch gears and also talk about my role and my day and what it looks like in the ICU, because I think that this is another area where many people don't have an understanding of what a day can look like. So again, my day is very similar in that it is 7 to 5 p.m. But at 7 a.m., instead of going to see all of my patients, I actually get a sign out from the overnight ICU doctor. So I learn about what happened to my patients, usually up to 10 patients during the day. When I'm on overnights, then it's 20 patients. Sometimes even more than 20, but it depends. And after I find out about what happened to my patients, I go ahead and see all of them, and we start rounding at 8:30 in the morning. Now, rounds are just like in what they show on television. There's a group of people, there's your nurse, the bedside nurse, there is a respiratory therapist in the setting for the ICU because of the ventilators. There's residents, interns, fellows, and the attending. We all gather in front of a patient's room. We go through a presentation of the patient, what happened to them, and we go through a plan for the day. Now, something a little different about a critical care anesthesiologist, at least in my institution, is that I actually carry the airway pager for the hospital. And what that means is that, especially in the COVID pandemic time, is that if a patient were having trouble breathing and they needed a breathing tube, they would call us to go and insert it. So insertion of a breathing tube or intubation is something that we will do, we could get called to do at any time during the day. So oftentimes that can kind of break up the day, or we have to stop rounds for a little bit, go take care of that patient, and then come back. After we're done with rounds, we make sure that, you know, all the things that we had set up as our plan for the day for the patients are done. And then by the afternoon, I come back around and make sure that any updates that have happened, I've heard about. And then at 5 p.m., I sign out to an overnight attending. And just as a heads up for you guys, I will address generalized questions at the end of the presentation, so I'm not ignoring any questions that come through. Now, anytime you are a physician in certain specialties, you provide a service that has to be available 24 hours a day. So we as anesthesiologists need to be available in our hospital, especially the hospital I work for, where a sick patient could need surgery at any time during the day, any day of the year. So the hospital's open 24 hours a day, 7 days a week, 365 days a year, and we need to be there physically in order to be able to provide anesthesia to patients that need it emergently. So as a result, I do have to do shifts that are overnight. Some places they'll do 24 hours. I personally do overnight shifts, which are from 5 p.m. to 7 a.m. And because I am a critical care anesthesiologist, my overnight shifts are actually in the ICU rather than in the operating room. Now, I do want to teach you guys a little bit about different types of anesthesia that we can provide so that you can apply this information to our case in a little bit. Now, most people know about general anesthesia. General anesthesia is what commonly people think of when they get anesthesia, but that's not the only kind of anesthesia we can provide to patients for their procedures and their surgeries. With general anesthesia, when I go and talk to patients about it, what it means is that someone is actually going to be completely unaware of their surgery, of what happens to them when they undergo surgery, when they go into the operating room, things like that. And for general anesthesia, typically we provide some sort of airway for it. So that means that we will need to either intubate with an endotracheal tube, and this is what an endotracheal tube looks like. And the photo underneath the endotracheal tube is the process of intubation, where we actually do use a metal blade frequently, that's called a laryngoscope, to move the tongue out of the way and be able to put the breathing tube in the trachea, which is the cartilaginous structure that you can actually feel when you feel your own neck. So that is a plastic tube that goes in. It has a balloon at the end of it, so we're able to provide positive pressure in order to inflate the lungs and take over breathing for a patient. Now, with general anesthesia, the other thing I like to mention to people is that we actually provide anesthesia through the breathing tube. So our patients are typically inhaling the anesthetic gases. That's called a volatile anesthetic, and that's what keeps them asleep. Typically in this, mask that we show, there's no medicine in there unless it's a pediatric patient. Typically, the mask is for oxygenation ahead of time. Now, another thing that we can use, another breathing device we can use to help patients breathe through general anesthesia is a laryngeal mask airway. So that actually, it's kind of like this size. It's a mask that sits in the back of the mouth. So it does not go into the trachea. It just sits back there and allows us to be able to give breaths to a patient, or allows a patient to be breathing on their own with the help of the ventilator. And so this is another device we can use for general anesthesia. Another type of anesthesia that we can provide is called monitored anesthesia care. So for monitored anesthesia care, this is actually closer to sedation. Patients who undergo things like endoscopy or colonoscopy that receive an anesthesiologist, if they don't have any contraindications to monitored anesthesia care, we will then provide that, which is something where we allow people to be relaxed, we give them pain medicine. Oftentimes we do a propofol-based anesthetic as well, where a patient is sedated, however, there's no airway device inserted, and we can wake them up very quickly. It also means that sometimes patients remember parts of their procedure undergoing monitored anesthesia care, and even sometimes, when I care for really, really sick patients, I tell them that they're actually going to remember the entire procedure, but I'm going to be there the whole time to make sure that they're safe and that they get some relaxing medicine throughout it. Another anesthetic type that we can do that people are not as familiar with frequently is that we can provide a spinal or an epidural in order to numb up an area for surgery. So a spinal and epidural, they're two different kinds of techniques. A spinal is one where we would actually place a very, very thin needle into the CSF space, or the subarachnoid space. So you go through the back and you go through each of the layers of ligament, and you get into that space, you see CSF come back, and we provide a small dose of numbing medicine there that allows for the feet all the way sometimes up to the chest to be completely numb. A spinal is typically used for C-sections for pregnant women, so that they can be awake and be able to meet their baby when their baby is born, but they can also undergo surgery. Epidurals are, more commonly people think of for obstetric patients again, but we can actually use epidurals for other procedures, and spinals for other procedures like a knee replacement or a hip replacement. We can do completely under spinal or epidural to allow for someone to either be awake during the procedure or to just get sedation so they don't feel that sense of grogginess or kind of hangover feeling from anesthesia. Now, another really important part of being an anesthesiologist is being comfortable with understanding monitors and using monitors. Now, for every single patient, we need to monitor vital signs. So for the first question for you guys, what are important vital signs that anesthesiologists need to keep an eye on? I'd love to see your guys' responses on what are vital signs we need to keep an eye on as anesthesiologists. And of course, you can cheat a little by looking at this monitor, but this is something that we look at day to day and are very comfortable with managing this. Now, I will wait about 30 seconds to a minute to see some responses, and then I will move on. Okay, so I have seen some responses. We have some very good ones. So heart rate, blood pressure, oxygen saturation, respiratory rate. So these are all great. So the main vitals that we do keep an eye on are definitely heart rate. We definitely care about oxygen saturation. As you know from the COVID pandemic, oxygen saturation is an important marker of how well the lungs are working and how well your body is able to function, because you need oxygen in order to make your organs work. The other things like EKG is technically another vital sign that we would keep an eye on. And so that is another thing that is connected with heart rate that we keep an eye on. And then respiratory rate is an interesting one, because we definitely, in anesthesia, we can actually control someone's respiratory rate, because oftentimes they're on a ventilator and we are the ones that are setting their respiratory rate. Now, the last thing, blood pressure is a very, very, very important sign, vital sign for us, because patients can get very low blood pressure anytime we give them medicines and anesthetic medications. It's very common for them to get low blood pressure. Now, other things that we will use to be able to monitor vital signs include an arterial line. So an arterial line is similar to an intravenous line, except instead of a vein, we place a catheter in the artery. So anytime you actually feel your pulse in the radial artery right here on the thumb side of your hand, that is frequently where we can put in a catheter to be able to monitor a patient's blood pressure every single time their heart squeezes. This is really important for some of our patients that are very, very sick, that have heart disease, and we need to be able to safely get them anesthetized. As I said earlier, when we send patients off to sleep, that's a very dangerous part of the anesthetic. And as a result, if someone has heart disease, if they've had a heart attack, if they have problems with the valves in their heart, they could be at very high risk for dying when they go off to sleep. So an arterial line is something we can use to help us ensure that we can keep our patients safe through the process of going to sleep. Additionally, an arterial line allows us to get labs and specialized labs to be able to keep an eye on certain markers of a patient. A central line is another important thing that we will do procedures on. So arterial line is, again, it's a procedure where we insert a catheter into an artery. A central line is when we place a longer catheter into a vein, usually in the neck, sometimes in the chest, sometimes in the groin. Now, this is important for us because if we put in a regular intravenous line, sometimes our medicines can cause breakdown or damage of the skin in that area. And as you guys may know, intravenous lines don't always stay in the right place. So if they infiltrate, meaning they go outside of the vein that they're supposed to be in, then we would administer medications into the subcutaneous space, and that can be dangerous in certain situations. So a central line allows us to place a intravenous line, essentially, but a bigger one, into a larger vessel so that it is a more consistent and safer way to deliver certain medications. As an anesthesiologist, we have to be very good with pharmacology and knowing a lot of different medications, including their doses and how we administer them. What I love about being an anesthesiologist is I am really a jack of all trades in a lot of ways. I would also tell you guys that an anesthesiologist on an airplane is a very versatile and useful physician, sometimes more useful than an emergency medicine physician, because of the fact that in the operating room, as an anesthesiologist, I am my own physician. So I diagnose what's going on with a patient. I can manage and treat and come up with a plan. I'm also my own nurse because I can draw up medications. I can administer these medications. I can also place intravenous lines and be able to titrate medications. And then I'm also my own pharmacist because I can identify what kinds of medications I need at what dose and be able to think about what are the potential side effects of administration of those medications. So we're a very, very useful physician in any kind of emergency. Now, I wanted to get into a case. So if you guys were following me around, in this particular situation, I'm going to do a case that allows me to blend in both being an anesthesiologist and an intensivist or an ICU doctor, just to give you an idea of how this can look. So for our case, this is very, very common that we do orthopedic procedures on elderly patients. So our patient today is a 90-year-old male, and unfortunately he had a mechanical fall. So he fell while he was walking around at home, and he came into the emergency room and was diagnosed with a right hip fracture. Now his PMH or past medical history includes hypertension and moderate aortic stenosis. Now I want to ask you guys, do you know what aortic stenosis is? And you guys can go ahead and answer what you think that is, or if you don't know what that kind of disease is. I'd also love for you guys to answer about what hypertension is as well. That should be an easier one too. Okay, so hypertension is high blood pressure. Now, does anyone have ideas for what aortic stenosis could be? And this is a more challenging question, so I will wait just one more moment and I'll move on and we will talk about it. I have one answer for narrowing of the aorta. You're close, but not quite there. Okay, so we'll move on. In terms of medications, this patient is on metoprolol and lisinopril. And I'll just tell you guys that metoprolol is a beta blocker. That is medication that's frequently prescribed to patients with heart disease, but it specifically slows down the heart rate. It also frequently, when it slows down the heart rate, causes the blood pressure to come down. And lisinopril is an ACE inhibitor. It is a medication that's frequently prescribed for high blood pressure. So to move on, anytime we are taking care of a patient, we need to examine our patient because there's a lot of information that we can gather from seeing our patients. So in the anesthesia world, typically we would meet our patient for the first time as they're coming into the operating room. So we have to gather all of the really important information that we can from a patient very, very quickly, because there's not a longitudinal relationship with these patients like your own, pediatrician or PCP would have with you over a long period of time. We meet patients in a very short period of time and have to be able to identify what types of things a patient has, like comorbid diseases and things like that, that might kill the patient in the operating room. So for this particular patient, you find this patient is confused, his mucous membranes are dry, so that means, his lips are really dry and cracked. You listen and you hear a harsh systolic murmur in the second right intercostal space, and then you listen to the lungs, you hear clear breath sounds, and you also look at the hip and you realize that the right hip is bigger than the left hip, but both of them are soft when you push on them. Now, a couple things I want to highlight about this particular physical exam is that our elderly patients or our geriatric patients, they are frequently at very high risk for something called delirium in the hospital. So this patient being confused is a very, very common thing that we can see in the hospital with our older patients that come to the operating room. Delirium can be caused by not being able to get good sleep. Let's be honest here, in the hospital, you get woken up every 4 hours for vital signs. Sometimes if you're in the ICU, you have to be woken up every hour for vital signs. So as a result, patients can lose their ability to, they get confused by this whole process. Other things, if a patient has a lot of pain, so in this particular situation, this patient has a broken hip, so he is in excruciating pain. That can also contribute to this confusion or delirium. To move on, when you go through the electronic medical record, you get some more information. NPO for 36 hours. Do you guys know what NPO means? Love to see in the chat what you guys think that means. I have one response for nothing by mouth, which is perfect. So it's actually a Latin term that says nothing per os, and os is mouth. So that means that this patient has not been eating or drinking for the last 36 hours. So that's perfect. IVF is IV or intravenous fluids, and they're running at 75 cc's an hour. The patient has received oxycodone. Do you guys know what oxycodone is? What type of medication that is? And we have a response for opioid pain reliever, which is perfect. So oxycodone is a type of pill form of an opioid. There's many different kinds of opioids that we use as anesthesiologists. We're very comfortable with all of those different kinds of opioids. They include things like hydromorphone, morphine, and other more common names for those intravenous versions are Dilaudid. We also are pretty comfortable with, we say PO, meaning by mouth medications, or pill forms of medications like oxycodone. And finally, hemoglobin has gone from 14 to 10. Now, are you guys worried about that hemoglobin drop? And if you are, why do you think his hemoglobin has dropped? So there is a response for blood loss, which is perfect. So something that I like to bring up is that anytime someone has fractured a bone, that bone can bleed. There's a lot of vessels around the bone, and that can allow for bleeding to happen. And it's really important to be aware of that, because blood is a very important way to be able to have your organs work. And sometimes people need transfusions because of big blood loss. Now, the big question, you are going to try to get this hip fixed. What type of anesthesia are you going to provide to this patient for their hip fracture surgery? Based on the types of anesthetics that I had talked about earlier, what kind of anesthetic would you provide to this patient? So I have a response for general anesthesia. Are there any other ideas for other types of anesthetics we can provide to this patient? And I have a response for spinal as well. So that's perfect. So what I will let you guys I will tell you is that for our elderly patients, there are certain types of hip fractures that can be fixed with just what we say is a nail. So the orthopedic surgeons will identify if the type of fracture is such that it's amenable to just getting a nail rather than a full arthroplasty or complete kind of like repair. And so if a patient is undergoing a less invasive type of hip fracture surgery, a spinal could work really well for them. So we would then prevent the patient from getting worsening delirium or confusion by providing a spinal, because then we don't have to send them completely asleep and provide general anesthesia. Unfortunately, for this particular patient, you guys were correct in that general anesthesia makes the most sense for him because of the fact that he's actually really sick. So we will get a little more into that. Now, anytime you provide anesthesia, you have to come up with a plan in your mind about how you're going to provide the anesthesia. These are some of the areas in which we identify. And so when I'm working with a resident or CRNA, we talk about these particular areas. So lines, meaning what access do we have? How do we give our medications? In this particular situation, we want a peripheral IV that allows us to give our medications through. And we also want an arterial line so that we can keep an eye on his blood pressure. For our airway, we will place an endotracheal tube. We are not entirely sure. This should be a couple hours long. So as a result, we want a longer term airway. So a breathing tube is one that we can keep in for as long as we need, whereas a laryngeal mask airway, typically we don't keep it in for very long because of the fact that it can push on a lot of pressure on the tongue and sometimes cause neuropathies, meaning some numb areas. So we try not to leave that in for very long. Induction. So as I said earlier, this is like the plane taking off. How do we send the patient off to sleep safely? Well, in this particular situation, we are going to be using propofol, which is our type of anesthetic medication. It's most famously known for the fact that Michael Jackson overdosed on it. Most importantly, though, for you is that you should never allow a non-anesthetic provider to provide propofol because it seems like a easy drug to use, but it's really a dangerous one in the wrong hands. Phenylephrine is a type of vasoactive agent. So that is a medication that actually brings blood pressure up. And then rocuronium is another medication we very frequently use, which is a neuromuscular blockade agent. And that allows for muscle relaxation, which helps with surgical approach and for the surgeons to do their part. It also allows us to put the breathing tube in very easily. Now, when you get into the operating room, you decide, you get all your monitors on, you have your arterial line, you go ahead and provide a propofol bolus, and the blood pressure is now 40/20. Now, is that a normal blood pressure? I'd love to see from you guys what you think a normal blood pressure is and what this blood pressure, if you're worried about this blood pressure. So I see that 40/20 is a very low blood pressure, and that's correct. Now, what is a normal blood pressure? What blood pressure do we typically target when we are caring for patients, or what do we want to see when we are seeing patients in clinic? I have a response for 120/80, which is exactly right. So that is a normal blood pressure that we're typically aiming for. And this particular patient's blood pressure is extraordinarily low. It's very dangerous. And it's to the point where actually you may even need to start CPR because it is so low that many of our medications are not able to circulate properly. So because of this low blood pressure, the case is actually canceled because this was an unexpected event. So we decide, okay, instead of proceeding, we should get the patient more safely prepared for surgery rather than put them through a surgery that may then lead to their death. So the case is canceled, the patient is woken back up, and the patient is taken to the ICU. Now in the ICU, anesthesiologists and intensivists like me can care for this patient and and evaluate and decide, what happened here? Why do we think this particular patient had such a low blood pressure? Now, it actually goes back to this aortic stenosis that I was alluding to earlier. Aortic stenosis actually refers to narrowing of the aortic valve. So it's not the aorta, but it's the valve, the door between the heart and the aorta. So this valve, as you get older, some patients end up getting more calcium buildup and it gets narrower and narrower, hence the stenosis part. And so as a result, what happens is the heart has to really work very hard in order to squeeze through a really, really, really narrow orifice, which is the aortic valve. Aortic stenosis is very dangerous for anesthesiologists because of the fact that if a patient has lower blood pressure, it's very difficult for the heart to be able to keep up and maintain the blood flow across the aortic valve, and a patient can die very quickly. And so as a result, these patients are very sick. They all need an arterial line. They oftentimes need very, very careful titration of our medications. Medications like propofol cause blood pressure to fall very frequently. Even healthy patients, you or I, if we underwent surgery, if we get propofol, our blood pressure will fall, but typically healthy patients are able to compensate for it. Their body is able to change something else to maintain their blood pressure. So in the ICU, the patient is continued to be evaluated and monitored. It is determined that, as I alluded to earlier, the patient's mucous membranes, so their lips and everything were very dry. They had not been eating or drinking for a couple days. And so it was determined that the patient actually was hypovolemic, meaning that they didn't have enough fluid, they were dehydrated, and they had blood loss in that leg. So you guys were totally correct about that hemoglobin being an important thing. So the patient receives blood products. They're able to actually come off of that medication, the phenylephrine that was keeping their blood pressure up. So that's a good thing. And then they went back to the operating room, except the day of surgery, the patient goes into something called atrial fibrillation. Do you guys know what atrial fibrillation is? What's really cool nowadays with technology is that our watches can actually diagnose this. So I'd love to see what you guys think atrial fibrillation is. So I have a response for irregular heart rate. That's totally correct. So in your heart, you have an electrical system that typically allows for your heart to squeeze in a certain manner. Sometimes that electrical system can go awry. So your normal heart rate that you would feel or see on an EKG is now erratic. So what atrial fibrillation means is that the chambers of the heart are called the atria and the ventricle. So the atria is kind of like the higher part. That's where blood goes in first, and then it goes into the ventricle. So the atria is where the place that electrical activity starts from. If that electrical activity goes haywire, then what can happen is that instead of doing a normal squeeze, the heart will then just fibrillate. So it won't squeeze, it'll just fibrillate like this. So that causes an erratic heart rate, and that is what atrial fibrillation is. Now, it's very typical for these patients, the older patients, to have atrial fibrillation. It's actually very common for patients not to even know they have atrial fibrillation. So this is not something that's going to stop us from proceeding with going to the operating room. However, it does sometimes indicate other kinds of things are going on. Atrial fibrillation can be an indicator that you're having a heart attack. It can mean that your heart is not healthy at that point. And so it's important for us to investigate whether or not we need to do further testing on a patient prior to taking them back to the operating room. In this particular patient's case, the patient had had a history of atrial fibrillation, so this is not a new thing for them, and we decided to proceed to the operating room. Now, in the operating room, again, this is a new anesthetic, so as a result, we need a new plan, and we, of course, do not want to repeat what we did last time. So this time around, again, we have a peripheral IV. We also have an arterial line. We are going to do an endotracheal tube again, but this time, instead of propofol, we're going to use a different medication called etomidate. Now, etomidate is a medication that is specifically made to try to prevent lower blood pressure from happening. It's also an anesthetic, so it allows a patient to be sent off to sleep, but generally it doesn't cause as much blood pressure drop. So you're able to give the etomidate, you use a little phenylephrine to keep the blood pressure higher, and then you give rocuronium so that you can intubate. And in the operating room, it can look something like this when they get hip fracture surgery. It's quite an uncomfortable bed that they are in, and their leg is extended in an awkward position. But you go ahead and are able to anesthetize the patient. They receive surgery, and they tolerate their fixation under general anesthesia. At the end of the surgery, you then turn off your anesthetic medications. You wake the patient up. You take out that breathing tube, and you take him to the ICU because he came from the ICU. And in the ICU, he recovers and he gets physical therapy and gets discharged to a rehab. So that's the case and presentation I have for you guys. I did just want to highlight that I love to share about my life as an anesthesiologist and answer questions about being a critical care anesthesiologist through Instagram as well as through Twitter and my new YouTube channel. Now, I wanted to circle back and answer the question that was posed earlier, and I'm going to answer any other questions you guys have as well. So to start from the top, earlier someone had asked about the eating and drinking and why that's impactful, why that has negative consequences for patients. This particular person had a very insightful comment that if you don't eat or drink, you might be dehydrated and you might have a lower blood pressure as a result. Now, what is important from our perspective is that when we send someone off to sleep, patients lose their muscle tone, and as a result, if there's food in the stomach, it can come up or regurgitate up, and when that food comes up, it can go into the lungs because when someone is anesthetized, they no longer have reflexes to cough or to be able to get that food particles out of their lungs. And so as a result, that's dangerous. If there's food that ends up in your lungs, you can get a pneumonia or you can get an inflammatory response like the ARDS that you can see with even COVID. And that can cause someone to need to be on a ventilator for a long period of time. So we try to make sure that our patients are not eating and drinking, at least not eating before they come in for surgery. Patients can drink clear liquids up to 2 hours prior to surgery, and that's usually relatively well tolerated after they go to sleep. Now, another question is about long-term complications OB patients can experience post-spinal or epidural. That's a really great question. So typically there are not that many complications that can occur from spinals and epidurals. We also are very cognizant of making sure to look at our patients' labs ahead of time in order to determine if a patient is safe to receive an epidural or spinal. So that means that all of our patients need to have a certain amount of platelets because they need clotting factors, and their coagulation numbers also have to be normal in order for us to place an epidural or spinal, because the complication that we are most worried about is an epidural hematoma or bleeding in the spine. Bleeding in the spine can compress on the different nerves within the spine and could cause paralysis and significant pain. And so as a result, that is the complication we are most scared of. I will say that it is such a rare complication that I have yet to see this ever in my career, in my training. I've never seen an epidural hematoma, and I've never seen bleeding in the spine from our spinals or epidurals. Now, in OB, something that I like to bring up is that frequently patients after their spinal or epidural can say they have a little bit of back discomfort. Frequently, the back discomfort feels like a bruise in the back where we place the epidural or spinal, and that goes away within a few days. But other kinds of back pain or leg pain can happen because patients are numb when they are laboring, and their legs are oftentimes in positions that are not really physiologic or not normally comfortable for them. I know that there was another question about how many hours do I typically work per week. So I'll say that as an anesthesiologist, you can kind of choose what type of practice you want to work in. Some anesthesiologists work part-time and can work 30 hours a week, and others like me, I'm technically full-time, but my schedule can vary pretty significantly because of my overnight call. My overnight shifts are 14 hours. So if I do a couple overnights in a week, I'm already at 60 hours a week. So some weeks I will work 40 hours a week. Some weeks I will work 60 hours a week. It just depends. And that's my current setup, but there's other people that can work less or more depending on what their practice is set up as and how much they want to work. So if you work more, typically you can make more money. Question is, can the calcium accumulation in aortic stenosis be removed somehow? That's a great question. So instead of removing the calcification, what we do to handle aortic stenosis is actually replace the valve. So if a patient is relatively safe, they can undergo, or is relatively healthy, they can undergo open heart surgery. They cut out the valve and they put a new valve in. Nowadays, we have new minimally invasive techniques. So we're actually able to use a vessel from the groin and put a catheter into the aorta all the way up into the heart and then deploy a valve within the calcified valve. So you're able to get a new valve inside of the valve, and that fixes the problem. The next question, how do you deal with stress on a daily basis and make the right decisions on the spot? That's a great question. So in anesthesia, it can be really scary because if someone has suddenly low blood pressure or has a critical event like their heart stops, we have to think very quickly on our feet and be able to manage that. What I will say is that it has taken a lot of time and experience to get to the point where I'm very comfortable managing really sick patients and knowing that how to kind of trust myself and trust my decision making. The other thing too is anesthesiologists are very much team-based players. So I have no concerns at all about calling my colleagues for help. I actually recently had a patient where I had a very challenging time placing an epidural. So I called some experts in to help me because that is an area where I'm, if a epidural is relatively easy, I can place it. Even if there's some challenges there, I usually can place it. But sometimes it requires that I can call on my friends to get another set of eyes or another approach to a patient. So we're very much team-based. If someone has an emergency or unexpected event, typically all of our friends will come in, other anesthesiologists will come in to be extra sets of hands for us. So I think that the biggest thing has been that number one has just been like making sure that I take a moment to take a deep breath, think about what's going on and move forward. And recognizing too, sometimes if I'm in over my head, that I need to call on other people. And that's how I've been really able to manage that stress. I'll say residency was a different kind of situation. I was burnt out during residency. There was a lot of stress with the patients that we saw, some of the schedule issues that we had as residents and as fellows. And it took a lot of leaning on my friends, being able to really prioritize self-care, sleep, and prioritize being able to kind of refresh myself, that was able to get me through some of those stressful things. Why did I decide in anesthesia what it made it special for me? So typically in a medical school, after the first 2 years, you go into clinicals and you're able to really see for yourself what types of specialties are a good fit for you. When you go through the different specialties, what you frequently find is that you will work with different specialties and feel like certain people have a similar personality and a similar type of interest as you do. And frequently you kind of like find your people. So I felt like a couple things went through my mind. When I started medical school, I wanted to do everything. I wanted to, sometimes there's one point where I said, I want to be a pediatrician. There's another point I said that I wanted to be an obstetrician gynecologist. Sometimes I thought, well, why don't I do family practice? Then you get to take care of everyone and you get to have long-term relationships with patients. But as I went through rotations, I started to realize that I didn't want to take my work home with me. So that was one area where internal medicine and family medicine, pediatrics, there's a lot of paperwork and administrative work that I just did not have the heart to want to do as an attending. In anesthesia, we actually have very little paperwork we have to do. We have a lot of automated charting and things that go on in the operating room that allow us to focus 100% on a few patients. Rather than getting a whole long census of patients, we take care of only a few. And I really love that. Also, the other thing was I considered surgery. I like the operating operating room environment. And what you'll find is that there are certain people that really like that environment and thrive, and other people that really love the clinic environment, the office kind of based environment, and that's where they thrive as well. So for me, I really enjoyed that. And I really loved just the group of people that I met that were anesthesiologists. They were all calm under pressure. They were all really smart. They knew their physiology, they knew pharmacology, and they also were a group of people that were not looking to be like the captain of the ship or to get accolades or to get recognized. We are frequently forgotten about, honestly, but we play a really important role in the operating room. How long does it take to reverse effects of general anesthesia or to wake patients up? Do you use other medications to reverse, or simply for anesthetics to be metabolized? That's a great question. So it depends on the type of anesthetic. So if someone receives a volatile anesthetic, we actually measure what fraction of that medication is still in their lungs through our ventilator. And that allows us to, we say titrate, meaning we can turn off the medicine earlier when they're closing the patient's skin for surgery, so that we can time it to allow patients to wake up a little faster. Now, if someone has a very long procedure, that anesthesia can build up in their body, and that can take longer for them to wake up. So it really just depends on the patient. It depends on the length of procedure and things like that in terms of how long it takes to wake someone up. Typically, the only medications we predominantly reverse are the muscle relaxants. Everything else, we rely on a patient's own metabolism to get rid of it. Or in the case of the volatile anesthetic, we actually have them breathe it off. So that's not really a metabolism thing. We just need to make sure that we decrease the amount of medication so that they're able to breathe off the anesthesia. And typically, it's hard to say like how much time it takes someone, because we are, part of our training is to know when to turn off these medications so that the patient will be awake when the surgery is done. So it really just depends on the situation. And when we have residents that are learning how to do anesthesia, oftentimes we can find that the patients take longer to wake up. So if someone is fully anesthetized for a few-hour procedure, it can take like 10-20 minutes for a patient to wake up from a deep anesthetic. How did COVID change your daily life? So I'll say that I was an ICU fellow during the peak of the COVID in Boston, and it was crazy. I did a lot more shifts. The way we intubate patients is very different now because of the fact that we want to minimize potential of infection from the patient to us as anesthesiologists. And doing the intubation is actually a very high-risk procedure because the virus can, if a patient coughs, the virus can be expelled from their mouth, and we're right up in patients' mouths placing breathing tubes. So that was a really big change for us in terms of changing our PPE, having to wear N95s more frequently, and then also just not knowing how COVID would impact us long term. I think that was it. Those were the biggest, scariest things for me a year ago. Now I feel like what has changed in the hospital is that we all have to wear masks all the time. That didn't used to happen, and our visitors are really not allowed in the hospital as much either. So that's a really big change as well. Why not use etomidate instead of propofol all the time to avoid blood pressure drops? So that's a great question. Etomidate actually has a potential side effect of adrenal insufficiency, and your adrenals are a gland that can create different kinds of catecholamines like norepinephrine, epinephrine. It manages your blood pressure, manages your fluid status. They're a tiny, tiny gland that sit on top of your kidneys, and they're very, very important. And if they're insufficient, what you can find is that a patient will have low blood pressure and need extra hormones to be able to sustain their life or sustain themselves. And because of this particular side effect, we typically only use etomidate on patients that we feel like are really, really critically ill and are going to be monitored so that this potential side effect could be addressed. If you or I come in for surgery, it also has other side effects, like it can burn a lot, it causes nausea, vomiting, whereas propofol does not cause nausea, vomiting. It does burn some when we inject the propofol, but it is a much more a reliable drug. It is one that we use more frequently. So as a result, propofol is typically our an initial agent that we use. What is something you would tell yourself or that you wish you knew when starting your medical journey? What advice would you give to undergrads? So I would say that you really need to make sure that you want to do this field because there are a lot of bumps in the road. There are a lot of setbacks. When I was in undergrad, I will say, well, when I was in high school, I was a great student. When I got to undergrad, I had a 3.9 GPA before I transferred. And then I went to University of Michigan, and the engineering degree is a very challenging degree. And I got like my first C+ in something. I went to medical school and I failed my first exam. So there's going to be a lot of bumps in the road. There's going to be a lot of challenges and setbacks. And so it's really important to recognize that this is the right career path for you, because I find that some of my colleagues who maybe only did medicine because their parents told them to, or because they felt like they had to from external pressure, they end up resenting things. They end up not being happy throughout residency, or they just switch what they're doing for their profession altogether. And so it's kind of this big investment. If you think about it, medical school is really expensive. I have a YouTube video that talks about how, you know, it compared to being an engineer, it can take a number of years to ever get close to a total income that's the same, or total net worth that's the same as an engineer. So it's important that you know that this is the path you want to be doing, and not other potential paths along the way, just because it is a long and hard road. But it's well worth it if you find that this is your passion. I will just answer one more question and then we will wrap up. But can you talk about the strangest or rarest case you've encountered in your practice? Do anesthesiologists experience many unusual cases, or are they generally pretty similar? That's a great question. So as I kind of alluded to, there's a lot of different practice types that we can see as anesthesiologists. So we can work in kind of outpatient centers where patients will come in for a small surgery and then go home that day. And typically what happens is those patients have to be evaluated before they go to a center like that, because those centers are not hospitals. So I work in a hospital, which means that we see everything. And I also work in a very, very big famous hospital. So as a result, patients who get declined for surgery at other hospitals will come to our hospital for a second, third, sometimes fourth opinion from a surgeon from our hospital. So we see a lot of crazy stuff. I will say that it's not the strangest or rarest case that I've seen, but one of the cases that really stuck with me was, a special kind of bone tumor is called a chordoma. Sometimes these tumors can grow to be so big that they take up a lot of the space of the spine. It grows off of the spine. And I enjoy doing these types of procedures, but basically they are two-stage procedures where you actually spend a lot of time, the surgeons will spend a lot of time trying to get the tumor mobilized and be able to safely try to take it out. So it takes 2 different days to do it, because you frequently have to go in the back and in the front to be able to get to all the different parts and be able to make sure that important structures are not like cut by accident. So for example, some of these tumors can go around the superior vena cava, they could go around the aorta, and then while they're trying to cut around those structures, they can actually cut into the structures and cause massive blood loss. So for this particular patient, we actually had to transfuse something like, I think like 20 liters of fluid. So a body has 5 liters of blood in it. So we gave 20 liters. That meant that we gave 4 times a patient's total blood back to them, because that's how much blood loss they had. So I'd say that was a very memorable case of mine, but we definitely see rare and crazy diseases at Mass General, and we get to be a part of the anesthetics for that as well. Okay, thank you again to Web Shadowers for inviting me to do this talk. Again, feel free to reach out to me via my social media sites if you have more questions, and thanks.
Thank you so much, Dr. Shi, for this wonderful presentation. It was so informative, and thank you for taking the time to answer all of our questions at the end. We really, really appreciate it. For everyone still watching, the Google form has been posted in the chat box and will be posted in the description of this video shortly. And you have 30 minutes from now to fill that out. And once again, Dr. Shi, thank you so much. This is an amazing presentation.